everyone, it's Patrick back. Thanks for dialing into the stroke session number 36 in the series, and we'll do a little bit of housekeeping before we get underway. As usual, to those that are regular attenders, and I can see that there are quite a few of you there, so welcome back. You can enlarge the screen by hitting that expand icon above the slide, and just press escape to get back to the facility where you can present a question to Liana, who will endeavour to answer those as we go along, if not at the end. So feel free to type a question in as we're going through the presentation. And this session is being recorded as usual and will be available on eStroke in the next week or so. So if any of your colleagues were unable to get onto the session due to the time or day, whatever, they can certainly access it via eStroke. Need to register as a member, which costs nothing, and access the resource library to find this stroke session eventually, and all other previously recorded sessions. So on behalf of the Victorian Stroke Clinical Network, welcome to this stroke session number 36. I'm the Regional Stroke Coordinator, and I'll be moderating the session. Today's topic is research translation of sensory assessment and treatment approaches with stroke survivors. And our presenter today is Liana Cahill, who's a research occupational therapist at the Florey Institute of Neuroscience and Mental Health at the Melbourne Brain Centre at the Austin campus. So thanks, Liana, and over to you.
Thank you very much, Patrick. So as Patrick was saying, my name's Liana Cahill, and I just wanted to make clear my affiliations before I start. So I am an occupational therapist and an occupational therapy researcher based in Melbourne, and I'm based at the Florey Institute at the Austin campus. I'm also a postgraduate student looking at knowledge translation for the area of sensory assessment and treatment post-stroke, and that's through La Trobe University. I'm also a lecturer in occupational therapy at Australian Catholic University. So today's focus will be on somatosensation. So when I talk about sensory assessment and treatment, I'm referring to somatosensation. So that is the bodily sensations. And I'm also focusing on upper limb therapy, and that's the focus for a knowledge translation study that I'm involved in. So I'll just go through an outline of the session for you. So what I'm hoping that we'll cover today is really to review somatosensory function, so to have a look at what's considered under the banner of somatosensation, to address the impact of sensory loss and the prevalence of sensory loss after stroke in our clients, to consider the evolution of the evidence for sensory rehabilitation after stroke. We'll also be current clinical practice in sensory assessment and treatment, and that will come from some research that's been done here in Australia and internationally. We'll be looking at some quantitative assessments for sensory loss, and then we'll do a bit of a world tour of clinical guidelines to get a bit of a state of the science for somatosensory treatment. I'll then introduce you to what is the focus for knowledge translation in the project that I'm involved in, and that's SENSE therapy. So I'll give you a bit of an idea of what therapy involves, and I'll then talk about the SENSE Implement project, the implement relating to the knowledge translation side of the project, and then we'll have some time to conclude and then address any questions. But as Patrick introduced, if you have any questions along the way, please type them in and I'll endeavour to respond to them along the way. So now I really don't need to tell a forum of health professionals in the area of stroke about stroke facts and figures, but I do want to highlight the epidemiology in this area to provide a bit of a backdrop for somatosensory rehabilitation and the knowledge translation study I'm involved in. So many of you would be aware of the influential global burden of disease study that is conducted regularly, and what it has told us is that there's an increasing global prevalence for stroke. So this is part of an epidemiological shift that has come about through low and middle income countries increasing their overall risk factor prevalence through adopting increasingly Western lifestyle factors involving dietary patterns and urbanised, more sedentary living. So overall global population ageing has also contributed to this increased incidence. And in a Deloitte Access Economics report, which was commissioned by the National Stroke Foundation for last year's report called No Postcode Untouched, it determined that 440,000 Australians live with the effects of stroke. But with this increasing prevalence, by the year 2032, this number will reach 700,000. So this will result in an ongoing and intensifying need for rehabilitation interventions. And as an additional reminder, we know that 2/3 of stroke survivors require care of some form each day, and that a significant proportion report unmet needs. So in talking about somatosensory function, somatosensation is our ability to interpret somato, or bodily, sensation. And when we talk about sensation or somatosensation, we're referring to the detection, discrimination and recognition of sensation, of submodalities of sensation such as light touch, pressure, temperature, vibration, limb position sense, so proprioception, kinesthesia, functional tactile object recognition, nociception, so pain, graphesthesia, two-point discrimination, and texture discrimination. And just as a point related to functional tactile object recognition, those working in the area of sensation often prefer that term over stereognosis, which is solely the cognitive aspect of object recognition. We often talk about haptic object recognition as being the true integration of not just the sense, but the meaning behind what's being felt in terms of an object. So you might hear haptic object recognition as replacing that idea of stereognosis in some situations. So we also, when considering sensory loss after stroke, research tells us that impairment in discrimination of somatosensory stimuli is the most common disorder after stroke. So that's things like telling the difference between textures, the size, shape and weight of objects, or telling the difference between limb position sense. And from neuroimaging studies, we know that the core brain regions that are important for somatosensory processing are the primary and secondary somatosensory cortices, the thalamus, insula, posterior parietal cortex, and the cerebellum. So I'll just go over very briefly the roles of those different areas. So our primary somatosensory cortex is predominantly involved in feature detection, and it does involve some higher level processing, for example, with the coordination of tactile and proprioceptive information required for object recognition. And information from the primary somatosensory cortex projects to the secondary somatosensory cortex, and this area has a role in the discrimination and the recognition of somatosensory stimuli, and it's considered to be specialised for tactile learning and tactile working memory. As another important area for somatosensation, the thalamus has an important role in gatekeeping of sensory information. The insula also has a major role in perceptual recognition and learning, while the posterior parietal cortex processes information for perception and for action. And finally, the cerebellum also has a role in processing somatosensory information, in addition to its role in modulating motor output, cognition, and adaptive motor skill learning. And one interesting aspect just around the cerebellum is that it's active during anticipation of somatosensory events. And this anticipation, the firing that occurs at a cortical level when we're anticipating a somatosensory event, is a feature of one of the therapy approaches that I will discuss a little later, so I'll come back to that. So upper limb sensory function is necessary for multiple functions. We consider somatosensation as essential for action. So this is such as reaching into a pocket to find one's keys or wallet, or just buttons unsighted. But also it's important for perception in allowing us to connect with our environment and those around us, such as the feeling of a toddler's hand in ours. And this feeling for the sake of feeling really cannot be underestimated in terms of its importance for interacting with the world around us. And I have had clients myself who have set some goals around perception, so wanting to feel the hand of their loved one as they walk along. So sensation for the purpose of feeling. Now, Impairments of somatosensation have a spectrum of severity and have been associated with impaired grasp and manipulation of objects, has been associated with poorer functional outcomes. Those with somatosensory loss have an increased risk of falls, and they also have been shown to have an increased length of hospital stay. And one of the qualitative comments that represents the experience of someone with somatosensory loss, this quote here describes someone who states, "How does one trust an arm that feels as though it's floating within the skin, or a foot that feels as though it has no real connection with the earth?" So despite some of these, the impacts of sensory loss after stroke has been labelled a neglected area of stroke. And it's been noted in the past the retraining of motor aspects has been that's been the focus. So sensation has been overshadowed by perhaps the motor recovery that's been focused on. But also historically, the retraining of mobility has taken precedence over the upper limb. So in this way, I sometimes think of upper limb sensory loss as experiencing compounded neglect. So it's important to highlight the prevalence of sensory loss after stroke, and a Cochrane review that was completed by Doyle and colleagues in 2010 stated that from the research we can say that up to 80% of people who have had a stroke experience somatosensory loss in their affected arm. So I'm referring now to a study by Carey and Matthias who looked at 51 stroke survivors, and they sampled this consecutively as these patients presented with their stroke. And they found that, first of all, for touch discrimination, 47% of those 51 patients had impairments in touch discrimination, and 49% had deficits in limb position sense. So what this has led to through this study and through other similar studies, in clinical practice, it's useful to think that around 1 in 2, or even more, but using 1 in 2 as a guide, 1 in 2 people post-stroke will have some degree of sensory loss. And what's interesting as well from some of these prevalence studies is that it's not just the contralateral hand that's affected. What's been found is that when they test the ipsilateral hand, the so-called unaffected hand that we sometimes use as a baseline for what would expect with sensory detection and discrimination, that also has been found to have impairments in touch discrimination and limb position sense when compared to norms, age-matched norms. So what we can tell from this is that there's a lot more interhemispheric activity and a lot of bilateral roles of our brain that really mean that the traditional, what we'd call the unaffected arm or hand, does experience some degree of sensory loss itself. So that just has clinical implications, as I mentioned, when we use that as a comparison when we're testing or treating. One point to make is that there's really no consistent approach at the moment to addressing sensory loss after stroke, but we'll review the state of the evidence, and then I'll talk about one of the knowledge translation project that's aiming to address this inconsistency. So occupational therapists and physiotherapists play a crucial role in the assessment and treatment of somatosensory loss after stroke. And I just wanted to highlight a study that I was involved in. It surveyed 172 occupational therapists and physiotherapists, and it looked at what the current practices were in the area of assessment and treatment. And I'll give you a bit of an idea of what the results told us. So this was an online cross-sectional study that therapists completed in their own time. And one of the most interesting things that came out of this study was that if you look here at the assessment areas, for the non-standardised clinical assessments, you can see that the top 2 things that therapists tend to assess is light touch, so either through fingertip or cotton wool perhaps, and proprioception or kinesthesia. So they might do a limb matching activity or get the person to mirror match their limb when it's moving through a particular range of movement. So those two, and I like to call these almost the bedside measures, the screening measures that therapists complete, were found to be the most predominant method of assessing sensation. And these results do correlate. They're quite similar to other studies in different parts of the world that have looked at what therapists assess. So light touch and proprioception are across the board the most common things that people look at. But what is interesting is that in terms of published assessments, so assessments that have more quantitative measures that allow you to look at what age-matched norms would be, 70% of therapists were not using any published assessments. So they were relying on the more informal clinical measures. And there has been a thought in the past, when we look at the prevalence rate for sensory loss after stroke, we know that it's much more common than was originally thought. It's likely that because we're using less sensitive measures to assess sensation, that we're probably missing quite a few clients who do have sensory issues, but we're just not using clinical measures that are sensitive enough to detect that. Moving on to looking at treatment. So what we can see here in the therapist reporting on the types of strategies or approaches they were using for treatment of somatosensory loss, compensatory strategies were the most commonly reported approach, and this can involve things like providing education to protect an affected upper limb from harm if they don't have protective sensation, or being aware of hot and cold if there's impairments in hot-cold discrimination, for example. But what we find is that these compensatory strategies don't always align with the state of neuroscience and what we know now in terms of neuroplasticity. So when we look at the specific or published treatments that were being provided, 32.7% of those that responded are not using any specific approaches at all to target sensation. And you can see probably from with mirror therapy that 40% of people are using mirror therapy, and that is recommended in guidelines for motor recovery, but there's less of an evidence base for the use of mirror therapy for sensation. There is some, but it was interesting to us that therapists are choosing to use mirror therapy specifically for the remediation of sensation. So there are other examples of this evidence practice gap, and one study that was quite similar was completed in the United States, and this investigated the practice patterns of 145 occupational therapists working with stroke survivors. And it found that although 93% of clinicians regularly assessed upper limb sensory function, only half reported always or frequently providing interventions to target upper limb somatosensory loss. And in another study, it was a smaller study but used qualitative design and used semi-structured interviews, there were 14 therapists, again in the United States, who were asked questions about their clinical decision-making in the area of sensory assessment and treatment. And just a couple of qualitative statements that stand out from this article is that one statement was, the thing is, if I find a deficit, then I'm kind of like, okay, what am I going to do about it? I can make them aware of it for safety issues. If I get someone who has severe sensory problems, I'm at a loss. So a little bit more information that highlights how quite a few therapists are feeling in this area, and the occasional lack of confidence that is experienced when someone has a client with sensory loss. And an overall report from both of these studies was that therapists don't feel up to date with where the evidence is. So I just wanted to introduce you to some quantitative measures of somatosensory function. So we know that most clinicians are using just bedside type screening measures for sensation, but part of the implementation study or knowledge translation study that I'm involved in looks at introducing some methods to be able to assess sensation after stroke much more quantitatively. So I've got just some images here that show you the equipment that's used for assessing somatosensation. And on the left, you can see what's called the tactile discrimination test. In the middle, there's the wrist position sense test. And then on the right, there's the functional tactile object recognition test. So to briefly describe how these assessments work, so the tactile discrimination test is a quantitative measure of ability to discriminate differences in finely graded texture surfaces. So you might be able to see in the picture there are grids that are involved in this assessment, and the patient is provided with 3 alternative forced choice design. So the participant tactually explores the set of texture grids with their preferred finger, and most patients opt to use their index finger for this, and they indicate of the 3 different textures that they're feeling, they indicate which of those is different. And the interesting thing about this assessment is regardless of whether someone has, say, a degree of spasticity or a lack of motor control that would prevent them from actually exploring those surfaces, the therapist is able to guide them along and is still able to assess them in this way. So the wrist position sense test, which is represented in the photo in the middle, is a quantitative means of measuring proprioception. So you can see what's called the proprioception retractor box that's set up there, and there's a hand and arm splint that a patient is positioned in, and they're then taken through different degrees of wrist movement from varying degrees of flexion and extension, and they need to indicate using the black pointer that you can probably see what degree they feel that their wrist is at, because their vision is occluded, so they can't obviously see the position of their wrist. And then finally, the other quantitative assessment is the functional tactile object recognition test, which involves 14 common everyday objects that the patient is asked to explore with vision occluded. Sometimes we'll ask patients to put on the headphones that you can see there as well, just to block out any auditory cues. And the items that they're presented come in categories, where the categories differ in one type of sensory attribute. So it could be its weight or it could be its shape. And patients are asked to identify through the poster that you can see in this photo which item they're actually feeling. And then their results can be compared to normative standards. So all of these assessments have been shown to have high retest reliability and, as I mentioned, normative standards as well. So these pieces of equipment are used for assessment in the knowledge translation study I'm involved in, but they're also the same pieces of equipment that are used for treatment. So I'll come back to talking about the treatment in a moment. So to consider the evolution of research in somatosensory rehabilitation, similar to constraint-induced movement therapy with the work of Taub and those monkeys, the contemporary approaches for upper limb sensory rehab came from work with primates who were shown to be able to be retrained in sensory discrimination following lesions made to their parietal lobe. So following this early work, there were some single case studies that followed with quasi-randomised control trials emerging in the 1990s, with a particularly relevant study in 1993 by Cahill and Gutman that's still referred to in some of the clinical practice guidelines. It doesn't have the strongest methodology, but had some very interesting results. So additional studies followed, and then a synthesis of available research occurred with 2 systematic reviews in 2009 and 2010. And I guess the summary of literature in this area identified that there are a range of interventions that are being provided for somatosensory loss after stroke, and these include compression, electrical stimulation, thermal stimulation, magnetic stimulation, sensory integrative treatment, some robotics, mirror therapy, and sensory retraining programs. So I'll just go through one of the systematic reviews was a Cochrane review, and the other was a systematic review by Schaubron and Hillier, which looked at the evidence for retraining of sensation. So the Schaubron study involved 14 studies, and what they had done is separate the interventions into either passive or active approaches for sensory retraining. And when they spoke of passive approaches, this was where something was actually applied to the person without their involvement at all. So it is things like electrical stimulation, whereas the active training was conceptualised as exercises or retraining programs that involve some perceptual learning. So there was no clear evidence for the active approaches. Some of the passive approaches were shown to have beneficial effects on hand function, so grip, strength and dexterity, but it was still stated that due to the heterogeneous nature of the studies that no firm conclusions could be drawn. And then looking at a Cochrane review that addressed interventions for sensory impairment in the upper limb after stroke, included a similar number of studies to the Scharbrunn review. They included 13 studies, which overall had a total of 467 participants. Again, they found there was limited evidence for the effectiveness of treatments, and unfortunately studies were frequently of low quality, and they made the comment that further research was really needed before clear recommendations could be made. But they did state that there was some limited evidence for mirror therapy for improving the detection of light touch, pressure and temperature, and that there was some suggestion that thermal stimulation intervention could improve the rate of recovery of sensation, and that perhaps intermittent pneumatic compression for improving tactile and kinesthetic sensation could be effective also, but really pointed to the need for additional research in the area. So since those systematic reviews were published, a year after the Cochrane review came out, this study was published in the journal Neurorehabilitation and Neural Repair, and this study explored the use of SENSE therapy. SENSE in this original randomised controlled trial standing for the study of effectiveness of neurorehabilitation on sensation. So this RCT involved 50 stroke survivors, and the stroke survivors presented with somatosensory loss. It could be that they had issues with texture discrimination, limb position sense and or tactile object recognition. They were at least 6 weeks post-stroke, and the participants had a median. They were median 48 weeks after stroke. So there were some quite chronic stroke survivors. Some were a little bit more acute, even though all were past 6 weeks. So of the 50 participants, they were randomised to receive either somatosensory discrimination training, which is the SENSE approach, or the control group receive repeated exposure to sensory stimuli, so non-specific stimulation of their upper limb through either providing a certain level of touch or getting them to explore different objects. So each group received the same amount of therapy in terms of 60-minute sessions for a total of 10 hours. So they had 10 one-hour sessions in total. And they were assessed, their outcome measures, the outcome measure that was used was a somatosensory deficit score. So this is a composite measure that looks at different levels of impairment of somatosensation. So the randomised controlled trial had statistically significant improvements for those that participated in the intervention, so the SENSE therapy. They had quite a significant improvement on their somatosensory deficit score compared to the control group, and they completed a follow-up at 6 weeks and at 6 months, and interestingly those gains were maintained at 6 weeks and 6 months post-training. So this study really provided a high-level, good quality evidence of the effectiveness of a learning-based sensory retraining program for sensory loss after stroke. So that therapy approach, I should say, is the basis for the knowledge translation study I'm involved in. So I'll come back to the design of that study, but I'd like to go now through the clinical practice guidelines that exist in this area of somatosensory loss. And I'll start with our Australian National Stroke Foundation guidelines, even though we know that they are now a bit outdated and that we won't have our new guidelines until the middle of 2017, I think it is, that they're anticipated that they'll be released. So what was highlighted, though, in the clinical practice guidelines when they were released back in 2010 is that sensory-specific training can be provided to stroke survivors who have sensory loss, and that sensory training designed to facilitate transfer can also be provided. This is at level C evidence, though, so cannot be used in every situation, but some of the work that I had mentioned earlier with that study from Cahill and Gutman formed the basis of this recommendation, as well as some studies by Carey, Professor Liana Cahill, who was a lead author on the SENSE randomised control trial, who prior to this had done some other smaller case series experiments that contributed to this evidence base. So the National Stroke Foundation are quite open about recommending that clinicians look to other countries for their guidelines because they are more updated. So we'll now have a look at what some of the other countries propose. In looking at the US, they look at sensory impairment in terms of a few of the senses together. So they put somatosensation in with vision and hearing. And one of the overall recommendations is that patients should be screened for sensory deficits by appropriately trained clinicians, and it just gives a bit of an idea of the areas that they think are important for assessment. So looking at sharp, dull, temperature, light, touch, vibration, and proprioception. And they suggest using Semmes-Weinstein monofilaments to assess cutaneous sensation. In terms of treatments, they state that similarly to the National Stroke Foundation guidelines, sensory-specific training should be provided as well, and that patients with sensory impairment could be provided with a trial of electrical stimulation in conjunction with therapy where appropriate. So that came from some of the Cochrane suggestions that some electrical stimulation can assist in that area. In looking at Canada, so the Canadian best practice recommendations for stroke care don't really separate out sensory and motor function. So when they mention sensation in their guidelines, it's in a sensory motor way. So they suggest in broad terms that patients should engage in training that's meaningful, engaging, progressively adapted, task-specific and goal-oriented with an aim to enhance motor control and restore sensory motor function. So as you can see, quite broad. And then mental imagery is also recommended to enhance sensory motor recovery, and that sensory stimulation in the form of either TENS, acupuncture, muscle stimulation or biofeedback may be offered to select patients to improve sensory motor function. And then finally on to the UK Royal College of Physicians guidelines, who I guess this is a document in my experience that clinicians are going to probably most regularly just because of the fact that they were produced in 2012 and have incorporated a little bit more of the, I guess, there's more currency of the information there. So in their guidelines for sensation, along with saying that all patients should be assessed for altered sensation, they also state that in terms of compensatory strategies, the patient with sensory loss should be taught how to take care of the limb and to avoid injury. But they've also incorporated the sense therapy approach. They've stated that sensory discrimination training should be offered to people with sensory impairment after stroke, and reference some of the studies by Liana Cahill and the SENSE RCT that I went through earlier. So to give a bit more information about sense therapy, it's an evidence-based therapy targeting the loss of sensation in the hand following stroke. And as I demonstrated, the randomised control trial really gave some strong evidence that it has the capacity to improve sensation in the affected arm of a stroke survivor. And it's founded on neuroscience, perceptual learning, and capacity for neuroplastic changes in the brain. So it really does aim to capitalise on neuroplasticity and has a lot of perceptual learning in it. So the patient who's involved in this type of therapy really is relearning how to feel again. And the SENSE modules focus on 3 different aspects of somatosensation. So they look at texture discrimination, limb position sense, and object recognition. So the training draws on different principles, and these are things like attentive exploration, so where patients really encouraged to explore the sensation, and calibration, where they either use vision or their unaffected arm to recalibrate in terms of what they're expecting to feel. And the patient will often move the sensation from one arm or hand to the other to really make that comparison as to what should be expected, and they really relearn to interpret some of that sensory information. And anticipation and feedback are also used. So when I mentioned that the cerebellum's involved in anticipating, it's active when we're anticipating sensory stimulation. The use of anticipation trials is important here, where the individual will be asked to anticipate what it will feel like, and that gets those regions of the brain firing and prepares them also for then having the experience of the object or sensation presented to them. So the training in sense therapy, as I mentioned, involves the equipment that I went through earlier. So with tactile discrimination, those texture grids are used to retrain sensation. For limb position sense, the proprioception box with the splint attached to it is used for retraining. And for object recognition, different objects are required, and the features, the specific sensory characteristics of different objects are retrained using some of the same objects. And another important focus of sense therapy is that it involves linking some of these impairment-based training to occupational goals. So patients will select where they feel that some of the sensory impairment is having the most effect, and aspects of those tasks will be retrained in therapy sessions. So that the approaches for quantitative assessment and the sense therapy approach form the basis for a research translation study. So knowing what we know about the prevalence of sensory loss and the fact that there's an evidence practice gap that therapists are experiencing, meaning that patients are not having the health outcomes that they could potentially have, means that we found that there was a need for a knowledge translation study. So our aims ultimately with this project, and there's a team of us from the Florey that are involved in this, are to improve the outcomes for stroke survivors with sensory loss. But an ultimate aim of the project as well is to develop a template for knowledge translation of evidence-based stroke rehabilitation. So we don't currently have a synthesis of evidence for what actually works in translating evidence to practice in stroke rehabilitation. So the idea of this is to actually gain some information through the research to see what actually might work, and then develop a bit of a template that might guide others in the translational activities. So the study design is a within and between site before and after study, where we compare usual care, which is what therapists are currently doing, to the SENSE intervention. So in this study, we have 2 participant groups. So we're actually really interested in the clinicians, and we're focusing on occupational therapists and physiotherapists. And we also are obviously interested in the stroke survivor and how they respond to the provision of sense therapy. So the idea is that we provide the clinicians and the health organisations with some theory-based knowledge translation strategies, and there's a lot. Some of you might know quite a bit about knowledge translation theory, but there are a vast multitude of translational theories. We've selected to use the theoretical domains framework for our study, and that's been quite a popular theory recently. It's attractive to clinicians and researchers because it amalgamates a lot of psychological theory and really addresses behaviour change that is essential for changing practice related to incorporating research. So we've designed some pre and post implementation questionnaires that are used as our outcome measures. We're also using focus groups, and we'll be completing an audit of medical histories. For stroke survivors, we have a specific sensory assessment tool that involves the equipment that you've now seen to evaluate their upper limb somatosensory function. So the study has a number of phases, and we've started this study at 2 pilot sites. So we've collected data from 2 of our sites already and have really got an idea of what's happening within those health organisations. And the information we collect in the pre-implementation phase, so a baseline questionnaire and a focus group, really allows us to see what's happening within that health organisation from a somatosensory assessment and treatment point of view. And the idea is that we take that information, which often highlights some of the barriers but also enablers for changing practice, and we attempt to tailor our therapy package, so taking the SENSE therapy approach but moulding it a little bit if needed to fit into an organisation. So we're really interested in how therapists can really embed this practice within their clinical practice so that it can be sustained. So we're not focusing on just coming into health organisations here, collecting data and leaving. The aim is that we're trying to create a sustained change in practice that will benefit stroke survivors. So the pre-implementation phase, after collecting some of that information, moves into implementation phase 1. So this is where our research team visit a health organisation, and we provide on-site training in quantitative measures. So phase 1 is all about assessment. So it's a 2-tiered change in practice. One is changing practices around how you assess somatosensory loss after stroke, and phase 2 is really focused on changing practice around treatment. So in phase 1, we have structured it by having a series of 2 2-hour workshops where we provide training in how to use the equipment and how you would record measures of somatosensation. And during that phase, nothing changes with treatment. So clinicians provide what they would usually do, and we just monitor the results, and we conduct an audit of histories to see what is being provided. We also, after that phase, it moves into phase 2, which is the treatment phase, and we as a research team visit the health organisation again, and we provide training in the SENSE therapy approach to treat somatosensory loss after stroke. And in this phase, stroke survivors are provided with SENSE therapy, and we also complete an audit of patient histories. And at the end, our post-implementation phase, we complete a post-implementation questionnaire and another focus group to really establish how the process worked for the clinicians and what were some of the difficulties. Because this project by its nature will mean that we're learning from site to site, and this information that we gather from our 2 pilot sites that have started will inform how we approach our other sites as well. So we use implementation theory, as I mentioned. It's been noted that it's in the whole implementation movement, it's been increasingly noted that it's important to use theory when you're trying to translate research to practice. So we've used the theory I mentioned, the theoretical domains framework, to address domains such as knowledge, skills, social professional role and identity, optimism, social influence and emotion. So we look at those domains when we formulated our questions. So one of the sample questions from our questionnaire is, what do you see as some of the strengths of your organisation in supporting your use of new sensory assessments and treatments? And when we look at trying to tailor our therapy to suit the organisation, we consider another theory called normalisation process theory, which many people will be familiar with, and we think about considerations like, will SENSE approaches fit with the overall goals and activity of the organisation? And we have looked at which strategies really help moving research to practice, and there have been a few Cochrane reviews that review the effectiveness of different strategies for knowledge translation. And just one example of something we're using is clinical champions. So they're also called opinion leaders, but there's someone within a health organisation that has real influence over others around them and can effectively change the behaviour of their colleagues by fostering and supporting implementation activities. So we've needed to identify clinical champions at our sites and to support them in being able to foster other staff members to change their practices. And the interesting thing in looking at clinical champions is that it doesn't depend, their influence doesn't depend on, where they might be in the structure or hierarchy of a health organisation. It's really more about interpersonal connections that people have, and that you can draw on that unique communication network that a clinical champion has to pass on a message and try to change practice. So that's a bit of an overview of our project, and I hope you've had a bit of an idea now about somatosensory assessment and treatment, and that you understand a little bit about our knowledge translation study. But this has just been a bit of a snapshot of things, so I am very happy to take either personal contact with different questions, or obviously more than happy to take some questions that you might have now related to anything that I've presented.
Thanks, Liana. Patrick here, I might kick a question off.
Yep.
I was just thinking during that last stage of your presentation, it almost seems in a way that neuroplasticity is, while it's important for the stroke survivor's recovery, it's almost important in a way for therapists, etc., to take on board new information and approaches and translate it into practice. Yes,
no, that's exactly right. And I think most people are aware of the potential to draw on neuroplasticity, and I think most therapists would now like to think that they do so. But I think what we're coming up against is a history of practice where things might have been done in a certain way, and that when new evidence emerges that's based on our new understanding of how the brain works, it's actually really difficult to change practice, and it's much easier to fall on relying to the advice of colleagues or what you might have learnt years ago, rather than basing what you do on current practice. But it really, we know that some therapists do pick up these new approaches, but we also know that sometimes really concerted efforts are required to change practice. So I've just had some other questions that I can address. So one of the questions was, is there a minimum amount of sensation required for stroke survivors to participate in SENSE? So no, there's not a minimum amount of sensation required. Someone with complete hemisensory loss would still be eligible, and it's most likely they would definitely benefit from being involved in this project. So in terms of I've just had a question about how to get your own organisations involved. I guess the first point of contact is to contact myself, probably most easily via email. We do at the moment have 8 sites involved, and that was our original aim, to have 8 sites. Because one of the health organisations that are involved, really, some have approached us because they've heard of the project. Others, our pilot sites, had been involved from the formulation of the idea of the project. And the great benefit of this project is that we provide the on-site training, and we also provide the equipment for use. So we have had quite a bit of interest, but that doesn't mean that we won't be looking at including other health organisations in our project. So I'd definitely encourage you, Brendan, to send me an email. We have been involving some regional sites in Bendigo, and we also have a team in Geelong. We have one site in New South Wales as well. So how long does the SENSE training take to learn as a therapist? That's a good question. So last week there was a 2-day workshop that was run at the Florey Institute for OTs and physiotherapists, and these sessions, these workshops run, I think it's once or twice a year. So it's a 2-day course where a lot of multimodal educational materials are used, so you get a chance to watch some video clips of clients being assessed and treated, and Liana Cahill also invites stroke survivors who've been through the program to come in and talk about their experiences. So it's a 2-day course, but for the purposes of our project, when we come in to train the therapists, we're looking at 2 5-hour blocks, so it's a little bit more intensive. And we found that it's definitely a skill that clinicians need to practice, but some organisations, even not involved in the study, have purchased a DVD and manual that the SENSE that that has been produced based on the SENSE approach, and that's available through the Florey website. So some organisations have that already, and even though they can't use the equipment, they're using the principles of SENSE therapy to work with stroke survivors with sensory loss.
Liana, Patrick back, just thinking about the equipment that you described earlier in the slides, the
Yes.
3 different pieces of equipment, and I know that you indicated that sites participating in the trial, for example, would be provided that equipment that you described.
Yes.
If people are interested in sourcing those sorts of equipment, what sort of costs are we looking at?
Yeah, it's not a cheap package of equipment. It's been purpose designed for sensory assessment and treatment. So the figure that I've heard most recently is just under $5,000. So they're actually exploring different avenues to reduce the costs. One avenue that's being explored is 3D printing for some of the materials. So that hasn't come in at all, but it's just one of the things that is being explored. But yes, where the equipment is available, but it is costly, and we're aware that that in itself is a barrier for some therapists and organisations in terms of using this approach. Yes, just to respond to the knowledge translation study, have we considered using a control group of health organisations that did not get access to the SENSE training? That's a really good question, a good point, and that's how a lot of knowledge translation studies are designed, with a cluster randomised trial where some health organisations might receive the intervention and some not, which would have been a stronger design, but we're really a practical research project, and it's really about translating the evidence to practice. So that's why we're using the controls are really within our sites. So the control is the period of time where clinicians are not using SENSE therapy, and then we're using the time where they do as the comparison. But yes, it's a really good point. If we were more focused on just from a research point of view, probably would have had controls at different health organisations that didn't receive any SENSE training. Yeah, great. Any more questions at all? I'm happy to answer anything related to the presentation.
It's looking like there may be no other questions, but we'll give it a moment. But Liana, thanks very much for your excellent presentation. We always gratefully receive offers to present as far as the Victorian Stroke Clinical Network goes, and yours was another good example of some of the subacute and even chronic things that we're involved in stroke management these days. So thanks very much for that. And I think next month we've got a session further on knowledge translation as well. So that'll sort of I think flow on nicely from your presentation. But I'll just have a quick look to see if anyone's typing away. But at this point, it doesn't look like. People are now submitting their thank yous. But of course, you've already offered the ongoing contact if needed. If anyone has a question that they'd like to put to you beyond the confines of this session, by all means, go ahead and do that.
Yep, definitely. And I will respond. So feel free to get in contact.
Excellent. Well, I think what we're seeing now is just people submitting their thank yous. So great presentation, and thanks again on behalf of the Stroke Project team.
Right. Thanks for having me.
No worries. I usually get an analysis of numbers of people that have dialed and logged in, and any comments that they might make, and forward them across to the presenter down the track.
Great. Okay. Thank you.
Thanks again, Liana.
Okay. Thanks, Patrick. Bye, everyone.